Hi, everyone. I just want to welcome everyone. Good afternoon. I'm Dr. Eli Putterman. I am an associate professor in the School of Kinesiology at UBC, and I am zooming in from the ancestral, unceded, stolen, and traditional lands of the Musqueam people, where the University of British Columbia campus is located. Many of you are joining us from a different territory, and if you are interested in learning more about the territory of the individuals and the people of the land that you live and work on, you can visit www.native-land.ca for more information about your territory. The Dialogue on Aging public presentation series is sponsored by UBC's Edwin S.H. Leong Center for Healthy Aging and Providence Healthcare to provide our public presentations. Today, I'm very excited to introduce our speaker, Dr. Samir K. Sinha, MD. He is the Director of Geriatrics at Sinai Health System and the University Health Network in Toronto, a Professor of Medicine at the University of Toronto, a Fellow of the Canadian Academy of Health Sciences, and the Director of Health Policy Research at Toronto Metropolitan University's National Institute on Aging. Dr. Sinha is a Rhodes Scholar and is a highly regarded clinician and international expert in the care of older adults. In 2021, he was appointed to serve as a member of the Government of Canada's National Seniors Council and recently led the successful development of Canada's new National Long-Term Care Services Standard. In recognition of his significant and enduring contribution to clinical leadership in geriatrics, the Canadian Geriatric Society recently bestowed upon Dr. Sinha the 2024 B. Lynn Beatty Clinical Leadership Award. And we feel very fortunate to have Dr. Sinha here today, and I will pass it off to Dr. Sinha for the presentation.
Thank you very much, Dr. Putterman, and a real pleasure to be here. I want to share with you a little bit about the work that I've been doing around this idea of aging in the right place and why this really matters overall. So real honor to be here today. Really, like when we start thinking about aging, the first of all, I think we often hear these words tsunami quite a bit. People talk about these demographic tsunami, this aging tsunami, and this idea that we have this apocalyptic demography in front of us. But I always say that anytime you hear the person say the term tsunami as it relates to aging, I really start wondering how much they appreciate about aging or really know about aging. Because if any of you in the audience have ever heard of the baby boom, and I think all of us have, we've known what our demographic changes would look like well years in advance. And in fact, you may have just seen the recent report that came out from Stats Canada that's actually showing us how many centenarians, people living over 100, there will be by 2073, I think, and it's going to be over 100,000. So we know exactly what our demographics will be. We have various scenarios, but this idea that aging just kind of snuck up on us isn't really quite correct. If anything, I don't think it's a tsunami. I think it's more of an aging glacier from that perspective. What you don't really hear often is people talking about aging as a triumph, and that's certainly I'm certainly a glass half full kind of person. Because when I think about it, if you were born in Canada back in 1900, your life expectancy would have been about 51 years of age. Interestingly, in the United States, it was 47 years of age. So we were doing something right then. But the key is that when you look at our life expectancy now, it's about 82 years on average. We have one of the highest life expectancies in the world. And so when people say, what was the greatest accomplishment of the 20th century? People say, oh, we put a person on the moon. I think the fact that we almost doubled our life expectancy is something that we should celebrate, because now more and more of us are benefiting from a longevity dividend, or third age, as some people call it. And I think that's kind of an exciting opportunity to think about. So I've got a few presentation objectives. Number one, I want us to help understand how the pandemic and our experiences have influenced our views on where Canadians want to age. I want us to help appreciate how aging in the right place needs to begin with the development of age-friendly communities and more innovative and flexible models of community-based and community-led care. And then finally, help us understand what we all can do to better enable aging in the right place for ourselves and our loved ones as well. So when you just to situate ourselves, I think you can't really escape a talk on aging without having some demographics thrown at you. So here's my turn to do so, but hopefully in a visually interesting way. So when we talk about Canada's population, currently about 1 in 5 of us, we're just about to hit that cusp, that magic mark of 20% of Canadians being older adults. I think we're right now just shy of that, just 19%, and sometime within the next year we should cross the 20% mark. And why is that important? Because once you reach that 20% mark, if you will, then you become what the World Health Organization or the UN declare a super aged country. Interestingly, if we think about it, you go back 10 years, there are only a handful of countries that would have been in this category. Now there's close to 20, and by 2030, we expect that there'll be about 34, 40 countries where 1 in 5 or more of the population is 65 and better. But we also know that we continue to age as well. And one thing that we often hear quite a bit on the news when we talk about our healthcare system and the challenges our healthcare system is having is really the number of Canadians who are stuck each day in our hospitals as well. In fact, if you look across Canada overall, about 7,500 people are stuck in hospital and literally stuck. They want to go back to their own homes, but there's not enough home care available. They want to go to a rehab setting, but there's not enough rehab beds available. They need to go to a long-term care home, but there's just not enough beds of those available. And so ultimately, we start seeing that our hospitals are filled with people who don't necessarily want to be there or need to be there, but we have no other options. And that's kind of a term we use in Ontario, and I think probably across most of Canada, called ALC, or alternate level of care. It's a much more polite term than what you see in Britain, where they usually call these individuals bed blockers, almost ascribing blame to these individuals when we really haven't right-sized our system and invested in the right types of care. And the challenge is that it's not just that we have people literally stuck in hospital, but the annual cost of just waiting to go elsewhere is about $2.4 billion. And there's some estimates that, kind of a significant percentage of what we spend on long-term care in Canada, or long-term care services, is just about funding people to get that care in hospitals, because we can't give it to them in other settings as well. So we also know that our population continues to age, and by 2034, so 10 years from now, 1 in 4 Canadians will actually be 65 and older, or as I like to say, 65 and better. So we certainly are. We know, kind of what our horizon forecasts, and we know that between about 2030 to 2050, we will sustain that 1/4 of the population being 65 and older for a long while. And this is when this baby boomer population will actually firmly be in that 85 plus cohort, for example. And that's where we know that 1 in 3 people will need some form of long-term care services as well. And that could be care in a long-term care home or retirement home or assisted living setting, or home and community care as well. And so we see that, our population's aging. And then, of course, we've got headlines like these that really speak to, the challenges that we have, with our aging population, and how our hospitals tend to be very unprepared to meet the needs of our aging population, especially when so many hospitals have people stuck inside of them who tend to be older people. And then, of course, you've got politicians who, around budget season, give themselves standing ovations. This is a picture from the 2018 Ontario budget, when they talked about, we've got a solution for our seniors. We're going to build 30,000 new long-term care beds. That's going to be our solution. And I can tell you 30,000 beds cost more of around $8 billion, not $1 billion, and just to build that many new beds. And right now, Ontario is trying to build 30,000 new beds and trying to redevelop another 30,000, but they're struggling to even do that. Just the costs of trying to build big institutional settings to warehouse people, it's a very costly affair, and it's not really aligned with what people actually want as well. So right now, the question is, what are we even doing, and are we even thinking about what people want? So I love this photo. This is a photo that my physician colleague, Dr. Mark Nowachinski, he's a well known photographer as well in his own right, where he did a photo documentary photographing his older patients, and that got created in a National Film Board documentary called House Calls, or House Calls with My Camera. You can look it up; it's free to watch online, and it really ventures through the work that he's done in terms of pioneering physician house calls in Canada. And I joined his team as a young fan many years ago, and am the consulting geriatrician to the program. And he took this picture of me doing a consult with 97-year-old Nina here, and Nina. You think this is a picture where she's like, "Oh, you're such a gentle doctor." No, the conversation actually that he was photographing was where Nina was like, "I just got out of hospital. I never thought I would leave. I'm now back home. I'm never going back. I'm going to age in home, and I'm going to die in my own home. Do you get this? Like, this is what my goals are." And the question is, when Nina says this is what she wants to do, the question becomes is how ready are we to be able to enable this? Do we have enough home and community care available? Can we actually, support, what her goals are, and what her desire, is. So we know that our experiences shape our age because our perspectives, because we know for many older people, accessing long-term care services usually means having to leave one's own home or community, especially if you're living in rural or remote communities. Especially know that for especially in our northern First Nations in Ontario, for example, there are no long-term care homes, for example. And so a number of the elders in those communities, when I was consulting across them to develop our provincial strategy in Ontario, were telling me that they're terrified that if they need long-term care or long-term care home services, they're actually going to have to move to Cochrane, Ontario, or Timmins, Ontario, if you know your Ontario geography. And similarly, I'm sure there are examples like this in BC too, your big province, and you know that if people are living in rural and remote communities where there isn't a long-term care home, people will literally have to move to a place where they can. And that's really, really tough, especially when you have to leave your community to be institutionalized everywhere. A lot of the elders were telling me this is really of concern to them because, again, they don't want to be reinstitutionalized like many of them were, unfortunately, when they were younger due to our residential schools legacy. So we know that leaving one's community and being institutionalized and not being able to receive potentially culturally safe and appropriate care close to family and friends is an unfortunate reality for many people. And there also exists a universal desire to age in place amongst most older Canadians. And so, how can one actually enable this? We also know that small and remote communities often do not support service and healthcare economies of scale. So, again, how do we start thinking about the needs of these communities and these people differently? Because if we look at the rural problems with urban solutions, we're going to miss opportunities that actually exist. And we often take for granted what local community agencies, their staff, and volunteers can do to enable aging in place. So we also know that the pandemic has really shifted our perspectives, and we know that 91% of Canadians of all ages and almost 100% of Canadians 65 years of age and older report that they plan on supporting themselves to live safely and independently in their own homes for as long as possible. So how do we reconcile that? Now, I know I'm not sure what the protocol is. I see that Anthony, you've raised your hand. If you have a question you want to ask, I'm happy for you to pose it right now. Go ahead, or we can wait till the end and we'll have time for questions then. Okay, maybe that was a false hand, but I welcome anyone's questions, and we'll have plenty of time for those as well. So we know again, like when we think about the needs of Canadians, we know that there's this real distinct desire to age in people's homes for as long as possible. Yet again, I just showed you a picture before of the Ontario government, or the previous Ontario government giving themselves a standing ovation as they were, celebrating the fact that they wanted to, put all these people in long-term care beds, for example. So this was actually when I was tasked with developing the Ontario Senior Strategy. This was actually a picture with our oldest participant and respondent. This is Granny Wabanow. Granny, as she would love to affectionately be known by her community, was an elder in the Moose Factory, Moosonee communities in northern Ontario. And I met her during a fierce bingo match at the Elder Gathering Place in Moosonee. She was on a winning streak, and then of course I had to interrupt all of that because we were having we were going to have a consultation to ask the elders and other older people in that community, what mattered most to them to develop a senior strategy. And I can tell you what Granny said was what all of the people said, was that she wanted to stay healthy and independent as long as possible. She wanted to stay in her own home in the community. She was hoping that if she needed it, she could get the home care she needed, so she'd never have to leave her community. And Granny also was the oldest residential school survivor in Canada at the time. She was the person that Stephen Harper actually gave the official apology to on the floor of the House of Commons. Years ago. And again, this was Granny's desire, and I don't think there's anything weird about that. That's exactly what everybody tells me they would like to do as well. And so the key is, we know that there's this universal desire to receive care closer to home. And certainly with some of the work that we've done through the National Institute on Aging, focused on, what are those key tenets that people value, including being independent, productive, and engaged citizens as they live, leading healthy and active lives, receiving care closer to home, and support for caregivers. We know that this desire to have care closer to home or in one's homes is quite strong. And that's why we really focused on understanding how do we better enable this with the future provision of long-term care in Canada, one of our reports in 2019, and then also one of our more recent reports called Aging in the Right Place, basically supporting older Canadians to live where they want as well. So we talked about this idea of long-term care and this idea of how do we provide more care closer to home. And so when we think about long-term care, I've used that term quite a bit. I think it's important to define what we mean, because depending on where you are, for example, if you're in Manitoba, people call they don't use the term long-term care. They call if you're talking about if you use the term long-term care in Ontario, you're talking about a nursing home or a long-term care home. If you go to Manitoba, they call them personal care homes, and Alberta, they call them continuing care homes. I'm not 100% familiar with what the term is used, preferred term is in British Columbia. But the point is that these definitions vary right across the country overall. And so really, and if you actually go outside of Canada, when people use the term long-term care, they really talk about long-term care, like care that's needed over the long term. And so really, it really encompasses kind of this real continuum, everything from what you think about care, home and community care and supports, to care that might occur in a retirement home, an assisted living facility, in a long-term care nursing home, for example. And it really encompasses supports with people's activities of daily living, such as bathing, dressing, toileting, transferring, to higher order tasks like paying one's bills, doing one's banking, doing those sorts of things. And so it can be at that level. But we also talk about and care that can also occur either in a designated building, or it could occur in one's own homes through home and community-based care. And it can either be both responsive, so a person needs help with a bath, so that we're going to help them bathe, or it can be preventative, and the idea that maybe we're going to help people stay strong and steady, and do exercises so that they can continue to bathe themselves. And so there's these ideas of what could accomplish this care. And again, it can be delivered by paid care providers, paid home care workers or workers in a long-term care home. There are many unpaid caregivers providing care in long-term care homes, but also also in people's own homes. It can be provided by a variety of different organizations in a variety of locations. And again, we talked about care that can be preventative or responsive, and often can be supported by primary and specialty care providers. So this gives you a sense of the idea of what's encompassed in long-term care as far as the NIA has defined this, about thinking of that real continuum of care. And this is helpful because then this helps to frame what we mean by aging in the right place. Because the NIA defines aging in the right place as the process of enabling healthy aging in the most appropriate setting based on an older person's personal preferences, circumstances, and care needs. And this is where you get that idea of right. Because sometimes, people will say, I've had older patients who live on their own and they say, I want to receive palliative care at home. And I'm like, that's great, but if you don't have any money, for example, and you can't hire 24/7, personal support workers, the home care program can only provide so much care during the day. And so, while I know this is what your personal preference is, your circumstances and care needs probably dictate you need to have a different form of care. And so this is when we might look at a hospice setting, for example, or a palliative care unit as the place to receive. It may not be the number one preferred place, but it might. But how do we find the right place in that way? So that gives you a bit of a flavor for what we mean by right, or how do we create the right place by finding the resources and supports to enable to give people what's important to them. So we know not only do Canadians overwhelmingly prefer to age and receive care in their own homes and communities for as long as possible, it's also often far less expensive than care in continuing care or nursing homes as well. And we know that with our rapidly aging population, Canada has to do more to enable older adults to age in the right place. And so we kind of create a framework where we talk about the importance of promoting preventative health and better chronic disease management, strengthening home and community-based care and support for unpaid caregivers. We talk about the importance of developing more accessible and safer living environments, and also improving social connections to reduce loneliness and social isolation. And right now, we know that we have some real disconnects because if you look across our country, over 430,000 Canadians who are getting home care say they currently have unmet home care needs, while 52,000 are actually on our nursing home wait lists across Canada. So you really sense that, while we're providing home care in places like BC and we're providing care in nursing homes as well, the key is there's a lot of people who are waiting for this care or have unmet needs. And so the question is, have we right-sized? Are we providing the right amount of this form of care? And the answer obviously is no, when we have so many Canadians with unmet needs. So how does Canada, though, stack up against other countries around the world? And hopefully you'll see the visualization of this, but I'm going to use the laser pointer feature, so hopefully this will appear for you too. So this is actually a chart of OECD countries, and OECD is the Organization for Economic Cooperation and Development. I call it generally the Rich Countries Club. And what you see is this is the average kind of right here in the middle of the average of these 36 countries that are analyzed. And this looks at the percentage of the gross domestic product that a country is spending on the provision of long-term care services, so that full continuum that we just discussed, and basically says on average it's about 2%. When you look at where Canada stands, it's a little bit higher than average. That's good. In this average that includes countries like Netherlands, Denmark, Sweden, but also Turkey, Chile, Poland, and Mexico, for example. So a real swath of countries. So Canada's a bit above average, where we're spending just over 2%, for example. But when you actually look at other countries over here to the left, you see countries like Denmark, where they're spending almost twice what we're spending on the provision of long-term care services. So you can really see that, while Canada certainly is a bit above average in this comparison of 36 countries that include Lithuania and Slovenia and etc., we're still basically not spending as much as other countries in this space. And when you actually look at how we're actually spending those dollars as well, this is a different chart showing 21 countries over here, and basically it's showing kind of how we spend. So Canada's over here, if you can see this, and basically the point is that the majority of our spending that you can see in the light blue is really about spending on long-term care nursing homes, for example. Actually, only a small proportion of what we spend is around home and community care, which is what people really want. And actually, we have this pretty big gray portion here, which is on spending on long-term care services in hospitals, and that represents that ALC group, that population that is waiting in hospital because there's not enough home care in the community to send them home with home care just as of yet. So they're literally waiting in hospital to go to their own homes with home care, or they're waiting for a long-term care bed, for example. So it reminds us how much we're spending. That cost of waiting in hospitals is quite significant in Canada. And what you can see if you go to Denmark as a reference country, they spend like a tiny amount on people waiting in hospitals. They spend a much larger proportion of their long-term care budgets on providing care in people's own homes, and only a small proportion on care, a smaller proportion on caring for people in long-term care homes. So this is also just gives you a sense of what spending has looked like in Canada over the last 10 years. And let me just see here, because what you see overall is what BC is actually spending. So over the last 10 years, there's been a growth in the spending on care in nursing homes or long-term care, continuing care homes of 62%. But BC's actually grown its home and community care budget at a greater rate. Where I'm based in Ontario at the top, our growth in our long-term care home spending has actually eclipsed what we're spending on the growth in our home and community care setting. But BC is actually one of the majority of the provinces where they're trying to put more money into home and community care to help more people age in their own homes and communities, as well. So that's the good news. The question is, are we spending enough? And I'd still say we could spend a lot more, to right size, our healthcare system. And of course, there are policy people who say, you know what? Why is government spending so much money on providing care in nursing homes or on home and community care? We should just tell families to be better families. They should just step up, and daughters and sons should be caring for their moms and dads more often. The challenge is that with lower declining birth rates in our society, for example, and more people living in other provinces and around the world, we know that between 2019 and 2050, there's going to be 30% fewer close family members available to provide unpaid care. And those who are left behind, for example, those available caregivers, are going to have to increase their productivity by over 40% in order to meet the caregiving needs of their relatives and friends as well. So it really reminds us, for example, that we can't just simply, rely on families more and more. Yes, many families want to provide care, but we're going to have to do a better job supporting unpaid caregivers. But we have to also appreciate that's not a sustainable solution unto itself, for example. So when we think about, enabling aging in the right place, and this is one of my beloved patients, Mr. W, and I met Mr. W when he was 99 years old, and he started using a computer when he was 93. He used to go traveling every day on the internet to a different country every day, and then at the tender age of 99, he developed congestive heart failure and COPD, and he was bouncing in and out of hospitals. And I met him on his seventh hospital of the year, and by that point, that was a bit of a whopper. He came in after he had a fall and he had some pneumonia, and basically he became quite delirious quite quickly in the emergency department. And they catheterized him, they hooked him up to an IV, and then all throughout the medical students seeing him were saying, "Oh, he's a demented older guy, and he's likely going to have to go to a nursing home after this admission." Well, this is Mr. W in his natural habitat. We got him back home, and this was taken on his 100th birthday, where Dr. Nowaczynski and I went to go celebrate with him. And I love this picture because you can see by his gesturing, he was the one in charge, and he's kind of telling me, this is where I want to be, surrounded by my books with my birthday cards and that. So you're going to help keep me at home. And remember, I met Mr. W at 99. We kept him in his own home till 104 and 11 months. Not a bad track record, but again, one where we could demonstrate enabling aging in the right place. Remember, he had 7 hospitalizations in 2010. He had 3 hospitalizations over the next 5 years of his life. And again, when we were able to enable aging in the right place for him, we could actually make things work. So this is a conceptual framework of how the NIA has kind of envisioned this idea of supporting kind of long-term care, again, across this continuum, if you will. And I'll kind of break this kind of pyramid into a bit more bite-sized chunks here, because it reminds us that the majority of older adults are living healthy and active lives. They're active members of their community, and really, these are folks who have minimal issues and needs. But again, there are things that we can do to promote more independent community living. Developing age-friendly communities, for example. And that's a World Health Organization initiative, and over 1,000 Canadian communities are now officially recognized as age-friendly communities. There's also, with the cost of living issues, growing, people are like, can I even afford to live, in my own home or in the community? And so this is where creative ideas like home sharing, which can be an intergenerational opportunity. Co-housing is quite popular in BC, and there's a lot of things that are happening in that space. And thinking about what are the things we can do to improve home accessibility and modifications. And then there are other enhanced support programs. If you're a veteran, or if you know a veteran, you may have heard of the Veterans Independence Program, which is a really cool program that really supports older veterans with the additional supports and services that can help them remain in their own homes for longer, such as beyond what traditional BC home care would offer you. The VIP program will offer you additional supports with maybe housekeeping, maybe gardening, yard work, those sorts of things that can be the big difference between staying in your own home or moving into a care home. So what defines an age-friendly city or an age-friendly community? It's often a community that recognizes the great diversity amongst older persons. It promotes their inclusion and contributions in all areas of community life. It respects their decisions and lifestyle choices and anticipates and responds flexibly to aging-related needs and preferences. And this is the World Health Organization kind of diagram that really speaks to what makes an age-friendly city. And you can see, yes, there's an angle here. Let me get my laser pointer. I hope that works for you. It works for me. But you can see, oh, I got it activated properly. There we go. You can see there's an aspect here around community supports and health services, for example, but it also talks about the outdoor spaces and buildings that we live in. How are we getting around our community? Do we have adequate housing? And then how are we being inclusive and supporting older adults to stay engaged in their communities, and making sure that we have the right communication and information that can support people as well as they age. So then we think about people who might need a little bit more help. These are people who might have moderately complex care issues, and they might be living at home in the community, but this is where they would really benefit from community transportation services. There might be the opportunity for preventative home visits or reablement programs. These are quite strong features in the Danish model, for example. You may have heard of NORCs, or Naturally Recurring Retirement Communities, an affiliated program. In New York State, for example, they've actually legislated supports at the state level, where people who are living in buildings that are predominantly filled with older adults can access some funding, in some cases where they can actually have people support and create programming that can help people better age in the right place, age in place there. And then models that are popping up are really leveraging the value of community paramedics, who can often identify people in the community who may be running into trouble, and who they can better support, for example, to kind of get the supports they need in a more timely way. When we think about older adults who might have complex care issues and needs and are living in the community, but they need to do so with intensive supports, this is where we think about models to support unpaid caregivers. We think about interprofessional and home based primary care. We think about enhanced adult day program models. We think about supportive housing models of care as well. And in the United States, there is a good model called PACE, for example, which is a nursing home alternative program. So in the United States, if you're what we call a dual eligible person, so you're both poor and you need long-term care, you need a nursing home, so you're on Medicaid and Medicare, they have a model that's available in a number of different states, I think 29 US states, where you have the option of saying, I could go into a nursing home, or I'm going to go into a PACE program where there's a community agency that will now be responsible for providing me a range of supports for the same cost that it would cost for me to live in a nursing home. And these community agencies now become in charge of providing your primary care, get your access to specialty care. They're giving you home and community care services and things that can allow you to stay in your own home for as long as possible. It's a wildly popular program, and it really has proven to support older people to stay in their own homes. In fact, in one analysis, they said at 3 years, only 15% of these nursing home eligible individuals actually ended up moving into a nursing home because these programs become really creative where they leverage the power of community and the agencies involved to really say, how do we support this person to enable what aging in the right place means for them? So we really have a lot of choices and options because we know that these are Ontario numbers, when you're waiting in hospital to go elsewhere, so those ALC individuals, that's about $750 a day. When we talk about care in a long-term care home, that really costs about $200 a day. And when we talk about home care for a long-term care equivalent person, the Ministry of Health in Ontario says it's about $103 a day, so half the price of caring for someone in a long-term care home because you don't have all the infrastructure costs as well associated with doing that. And I mentioned Denmark a few times. Well, they avoided building any new nursing home beds over 2 decades and actually saw the closure of thousands of hospital beds by strategically investing more in the provision of home and community care services. And that's why, if you remember that chart, I showed you how in Denmark, they spend almost 2/3 of their spending on the provision of home and community care services. Because by doing that more, I'll tell you what their ALC rate is. It's not 15% like it is across Canada and it is in Ontario. It's about 1% because they can do so many things in people's homes and they actually have the services available to provide care in people's homes. And we know that medical and technological advancements are allowing more people to be able to receive complex care and support in their own homes. So what's really cool now is if you go to Denmark and you see brand new hospitals being built, a CEO will be very proud to tell you the new hospital being built is smaller than the current hospital that exists because they're able to do so much more in people's homes that they almost think that building bigger hospitals is a failure of your health system and a failure of your ability to care for people where they want to be cared for. So it's just an interesting mindset to see how they've been, re-envisioning care for older people and their societies as well. So this is an interesting graph because this actually shows that what I'm talking about isn't crazy or harebrained because people say, could we really support more nursing home eligible people to stay in their own homes? Like, is that even possible? So this is actually what we did in Ontario. So in Ontario, we basically said, look, so those blue lines represent the number of people 75 and older who are living in Ontario long-term care nursing homes. It's about 75,000. It stayed pretty steady over this period. And also during this period, what we did is we started increasing the home and community care budget by about 5% year over year, especially during this period over here. We were increasing it 5% at least a year over year. And by doing so, we were able to provide more home and community care. And by providing more home and community care, we were able to support more nursing home eligible individuals, to stay in their own homes and communities. In fact, by 2016-17 here, we had 90,000 people who were nursing home eligible but receiving home and community care. versus 10 years earlier in 2007, 2008. And that was more people than were living in our long-term care homes in Ontario. So it just reminds us that we can absolutely enable more people to age in the right place. If we tell our politicians this is what matters most to us, don't give yourselves a standing ovation, telling us that you want to have us be in nursing homes. We'll give you a standing ovation, if you want to help us stay at home. And actually, we kind of know what to do. We know how we can enable aging in the right place. This was Karen. She was a lovely lady who unfortunately developed dementia later on in life, and Karen had been living in this apartment for about 30 years. And Karen had a routine that she would do where she would go for her walk every day, and she would go buy chocolate milk. She seemed to live on chocolate milk and muffins for a number of years by the time we had met her, but she was kind of existing and living in this apartment. And she came to our attention because, unfortunately, during her walks with dementia, someone befriended her and then would add on to her walk a walk to her local bank or her local ATM, and defrauded Karen of about $70,000. Luckily, Karen had about 270,000 left in her bank account, so that was the good news. And we were able to support Karen. And for Karen, she wanted to live at home, and Karen was sitting on a lot of money, but Karen didn't have any family. So the house calls team, and that's my colleague, Dr. Mark Nowachinski, the photographer, who also did this photograph. Mark basically and the team has a social worker, an occupational therapist, that they basically made sure that we got Karen the support of the public guardian and trustee so that they could help oversee her money. We knew that Karen was really keen to stay in her own apartment for as long as possible, and they were able to use her funds to help provide her the right furnishings that she wanted and to give her the right care she needed so that she could stay in her own home for a few more years until, unfortunately, she had a hip fracture, and then we needed to provide her a higher level of care. But it just reminds us that even for a person who's living with advanced dementia, living in their own home, we can still provide a lot of care. And I'll tell you one more funny story, and then we'll get to our conclusion and questions. I remember when I was doing a home visit with Karen and Dr. Mark, I looked over, and she lived in this massive apartment building with 500 units. And we walked over, and I opened the fridge, and that's where I realized that Karen was only living on chocolate milk and muffins, but her blood work was pristine. So I don't know what to say about that, but you could try it. And then the other thing that deeply concerned me was that on Karen's stove, with the traditional elements, she had all of her mail stuck there. Well, that's just a bit of a concern, because if you turned on one of the elements, well, that will just heat up, and that's a fire, and that burned down the whole building. But the good thing was that when I was actually trying to turn on one of the elements to see if they worked, Karen slapped my hand because she knew that wasn't a good thing. Well, luckily, we got our OT in within a few days to actually unhook the actual the stove and put some safety measures in place there so that Karen wouldn't burn herself and the whole building down. So again, things that we can do. Takes a village to support, but we really can enable that community-led transformation. And so really enabling aging in the right place requires a shift in traditional thinking, much beyond how we've currently thinking about long-term care. And from enabling age-friendly communities to enable aging in the right place, we can create alternative housing options that can better promote independence, dignity, and respect. And enabling this can only succeed through collaborations and partnerships, and can ensure the sustainability of our health and social care systems for years to come. And so with that, I'm going to say thank you. And I believe we have exactly 16 minutes left for questions. So I would really welcome any questions that this group has. I don't know if you're traditionally a quiet group or a loud group, but thank you, Christopher, for raising your hand. I invite you to unmute and to ask a question.
Hi, Samir. Chris Rocher, geriatric medicine. Can you hear me?
I can hear you well, Chris.
Um, I'm interested in what you have found out about in countries that, such as Denmark, etc., that have low ALC rates, which is just a marker, of course, of actual community support. Um, Don Berwick from IHI said, you need a burning platform. And certainly the issues you raise are towards that, but it seems to me that the current burning platform is younger people who don't have adequate housing themselves for a variety of reasons. So I'm wondering in the countries that seem to do better, um, do they have co-living arrangements or other sorts of arrangements to try and bring forward uh, those two burning platforms, especially politically? The bigger voting bloc now is shifting towards younger people as well, like millennials, etc. So it seems like there might be an opportunity to try and join those to get more traction.
Yeah, it's a great question, Chris. Thank you for posing that. And because one of the big concerns that we're seeing now is this idea of this battle of generations, right? Almost these you'll remember, for example, like there's a lot of societal ageism. I think we appreciate that. It was quite disturbing during the pandemic when you'd hear comments that, well, COVID-19 is a boomer remover. You might have remembered that hashtag, quite disturbing. Or even the premier of the province next door to you, and I'll leave it at that, who in the legislature actually said the average age of a person dying from COVID-19 is older than the average age of a life expectancy of an Albertan. So I don't see if there's a real problem here. I'm like, oh my goodness. So, and you get this idea of intergenerational fairness. People are now saying, well, look at all these boomers who are sitting on their homes, for example, and we can't afford housing. And so how do you start, and then, oh, well, now they're bankrupting the healthcare system because they need all this care. And what about us, for example? So it really, brings in this idea of these intergenerational tensions and these and again, how do you also kind of solve some of these burning issues? And certainly you see kind of examples of co-living that to a certain extent have been pioneered or more active in some European countries, for example, that are thinking of innovative housing solutions. So, sometimes there are care homes that rent rooms to students, for example, who in exchange for a lower rent are actually providing, playing music or doing other things. You see, and you certainly, I can't say that it's a standard or it's a typical practice, but you see a lot more intergenerational housing developments that are occurring, and that idea that you're intentionally bringing communities, building intentional communities. And I saw a fabulous one in Denmark, and if you want to watch the video with CBC National and CBC Marketplace, if you type my last name and type Denmark or CBC in Denmark, whatever, you will find this piece where we actually filmed at a place called the House of the Generations, which was basically a 450 unit, let's say, apartment building in the middle of a whole housing complex. And it had a mix of nursing home units. It had assisted living, if you will, units, independent living apartments, and apartments for people, adults with disabilities, and people with families. And what you saw, what people intentionally were moving into this intergenerational community, was called the House of the Generations. But then you were naturally seeing kind of co-living, at its best, where where they would intentionally have a young family, and then they have an older person independent living next to them. And it was great because she says, I babysit and they get my groceries, right? Like, that there was these things that were starting to naturally happen. And people really finding the value of those intergenerational connections. But, to Chris, to your other point about, what are these burning platforms? Well, housing is a huge burning platform. There are a lot of older people who want to stay in their own homes. There's a lot of people who can't even afford the rent. And so, for example, in the Greater Toronto area, and someone on the call might know the BC data, but in the Greater Toronto area, they've said that we have about 5 million empty bedrooms. So people living in maybe a 2 or 3 bedroom house, they've raised their family. It's now just them living there, and the other bedrooms are free. And so we've seen an emergence in Ontario, and I don't know if it exists elsewhere per se, but the idea of home sharing, the idea that maybe I'm going to rent out these extra bedrooms that I have, to younger people who are looking for subsidized rent, and in exchange they might help with my groceries, they might actually help, help me with tasks, maybe provide some companionship, etc. And so that's like one of these win-win situations where you can actually help people, live in a place like downtown Vancouver, with enormous rents, or downtown Toronto, and also allow people to have more sense of safety and security. So this is where I think we have to be more intentional about things that we can do. And I certainly think that I've seen some good examples in Europe, but that's not to say that those things aren't happening in BC. And certainly I think BC is a little bit ahead of the curve, especially with some of the co-living work that's also occurring in BC as well. But I'll stop there, and see if there's if that, Chris, that hopefully answered your question, but also welcome others as well.
Dr. Sinha, we have some questions in the chat for you.
Sure.
One is whether you have a comment on the pros and cons of renting out one's house and renting an apartment closer to services while one is still active and not ready for a retirement community.
Yeah, and this is where I talk about like aging in the right place being like it really like everybody's different, right? Some people don't want to have people living in their house, right? Some people were like, I don't want to have roommates, I don't want to have housemates, I don't want that. Other people do. Like they really like the social interaction in that way. And so I think if I understood the question correctly, I'd always say it's first of all kind of like what matters most to you. I think as Chris is a geriatrician. We hopefully have other geriatricians on the line here too. But one of the common questions that we often ask in our practice is what matters most to this individual. And I really think that if a person really likes living in their own home, in their own community, then the question is, well, what are the things that might be threatening their independence? What things might be helpful? And every community is different in terms of the assets and the resources that it has. So a person may not have to have any roommates or people move in with them or renting rooms. They might be able to stay on their own if that's what they want, and then access various services and supports, or be able to navigate their community for that care and supports as well. And for some people, having that renting a room and having people come in might give them the income they need to do those extra things, or it might also be a way for them to give housing and have some intergenerational connection as well. So I can't say if there's so there's pros and cons, but I think the cons are more based on personal preferences, and I think the pros are about if that's something that you're willing to do. It could solve a bunch of different problems. It gives you a bit more money, it gives you a bit of companionship, and gives you some support. But of course, the cons could be, you're hoping that it's a good match and that these people are going to be good to you as well and not take advantage of you in that way. Christine, I'm going to let you navigate the other questions that are coming through the chat for us as well.
Sure, I don't see any hands up at the moment, so we'll keep going on here. You mentioned that 24-hour per day care at home is going to be extremely expensive. What are your views on the use of AI-enabled robots for caregiving services?
That's a brilliant question. So we did a report called "The Financial Realities of Aging in Place," because for a lot of people, they often underestimate grossly what it would cost to have like 24-hour care. In Ontario, I can't speak for BC. If someone wants 24-hour care, you're paying about $25,000 a month. That's if you're just call up an agency and said, send me a personal support worker or a healthcare aide, and send me the bill. Then that's kind of generally what you're paying. And I don't know about you, but I don't know a lot of people who have $25,000 a month. So that's a real challenge, right? In terms of when you think about the potential costs. And so, of course, people are saying, even from a human resources standpoint, we have a shortage of home care workers and workers in our nursing homes. So countries like Korea and Japan, where they're having significant worker shortages, and it's hard to import people who can't provide language concordant care. There are not many countries there's no other countries around the world beyond the Koreas that have large Korean speaking populations, or Japan in the same way. And so that's where you see a lot of this work around robots, and the idea of using robots and other technologies to try and say, could we actually have the robot provide care and therefore reduce the amount of the need to actually have human beings? And you can start seeing there's benefits and risks. For example, we don't have robots out there at the moment that could do a whole bunch of tasks, but there certainly are robots that can do some tasks that can minimize the need for humans. So, for example, in Denmark, one municipality, to really kind of better stretch their home care workforce, said, instead of us sending a person in to vacuum for an hour every week, for example, we're now just going to buy all of our clients Roombas, those robot vacuum cleaners, because they're going to do that, all throughout the time. And then that just saves us having to send a home care worker in to do the vacuuming, for example. But of course, the con of that is that what about the human interaction, right? Because it's not just that a human being's coming in to vacuum; they're having a conversation, they're keeping an eye on you. There is the benefits of human action, human interaction from face to face. So certainly there's a lot of work going on around AI and technology, and I'm about to start a sabbatical in Oxford that's going to be focusing all about technology and to enable healthy aging and aging in the right place. Because as you can tell, there are some really interesting ideas that are coming out. There's a lot of technologies that haven't worked or haven't proven to be useful, but there's also opportunities, but there's some challenges, ethical, security wise, financial, like all these other things that we need to think through and make sure that we have the right safeguards in place so we're not inadvertently causing more harm than good. So hopefully I answered that question, but there's some interesting robot technologies out there, but I don't think it's necessarily prime time. And the question is how sustainable is it and how cost effective is it as well?
Thank you. And we do have, of course, some thank yous, as always, for your great presentation and the chats there. And this one comes with a question about figure number 3 in your slide deck. Has the figure been updated? I'm curious if the trend toward home and community support continued, or if it tends to vary with political direction.
Tends to vary with political direction, right? So, if you will, I think if we're talking about the figure for Ontario, or what happened, if that's the figure we were talking about there, certainly there was a change of government in 2018, as an example. And while I had worked previously with the previous ministers of health to make sure that we started increasing the home and community care budget year over year by 5%, that's at a time when we were increasing the hospital budgets by 0%. And the long-term care home budget by 2%, or in inflation. We were accelerating the home and community care budget, but the new government that came in place, they just left home care to inflationary increases as opposed to accelerated increases. And then lo and behold, the long-term care home waitlist went from 32 to 43,000 people. Home care waitlists went up to 16,000 people at last count. And now we have the worst ALC situation ever before. And I warned them that if you do that, and I think Chris mentioned before, the root cause of a lot of these issues is you're just not providing enough home and community care in the first place. So yeah, it's all politics. And so after my Denmark documentary with CBC, it didn't shed a good light on the Ontario government. And then the former Minister of Health admits this. They panicked and they immediately announced $1 billion to increase the home and community care budget in Ontario because there was an election coming up and they wanted to do this as well. But I see that there's As we said, there's no time now, but another time we should have a session on equity and cultural safety issues with aging. I completely agree. It's another topic that I love to talk about. And Alberta asks, are presentations like these being presented to government leaders? Sessions like this are informative, but shared with already converted. So I will tell you, Alberta, I presented this directly to the Minister of Health in Alberta. I even took the Minister of Health for Alberta, Northwest Territories, Nova Scotia, and Quebec to Denmark. But I presented a version of this for the Minister of Health in Alberta at their Continuing Care Forum. And I'll tell you, if it all works out, I've been invited by the Ministry of Health in BC to potentially give a presentation this fall, basically along the lines of this, to give them encouragement and support. So wish me luck if that works out. I'll hear by the end of the week if that's a go. But absolutely, these presentations are being given as well. But it's always good to have good dialogues like this, because it helps to validate, am I saying the right things? Am I on the right track? And what can we learn from each other? Because it takes a village to support aging in the right place.